I'm David Brown, Director of the Virginia Department of Health Professions. Welcome to Virginia's core competency modules for pain management and addiction. These competencies were developed by work groups convened by Virginia's Secretary of Health. Over 24 experts in pain management and addiction compiled the essential competencies that Virginia's health professional students must acquire, not just our future physicians, nurses, dentists, and pharmacists, but the wide range of professionals who work with these types of patients. These modules, made possible by a Department of Behavioral Health and Developmental Services grant, present key parts of the competencies for use not only by our schools, but by practitioners already in the field. Thank you for your careful attention to this important information.
Hello, I'm Dr. Robert Trestman, Chair of Psychiatry at the Virginia Tech Carilion School of Medicine. This is Module 1, the challenge of discussing pain with patients. And now we're going to focus on topic 3 within that module, discussing pain with our patients. Pain conversations are difficult, and so it's really important to have effective communication in this context. Particularly when we're talking about working with patients who experience chronic pain, it's important to really keep in mind several factors. The first is it's so important to establish trust. A genuine relationship between you and your patient is what this is all about. To establish trust and to express empathy regarding the impact of the pain on their lives. It's important to consider the effect on the quality of their life, to review how their current treatment and the experience of the pain is affecting their life, and then to explore options. What might lead to a safer and more effective approach to managing chronic pain? So, in the context of these conversations, there are several things that you can do to make them more effective and to ease some of your own difficulty in having these conversations. The first is slow down. It's really important to take enough time to listen. It's important also to check often to make sure your patient is understanding what you are trying to convey and what you're hearing, to review and discuss the treatment options, to address the risks and benefits of each, and to emphasize your concern for safety that will enhance the quality of their life. It's also important to recognize your patient's uniqueness. People, as you know, never want to simply be treated as just another patient coming through your office. Everyone wants to be acknowledged by you as a clinician, as someone who cares about them. Address your patient by name. Recognize the effects of their culture, their experience, and the social influences on them, and the way that they would then express and experience their pain. It's important that you can listen reflectively to them, to try to maintain eye contact, to use appropriate nonverbal cues, demonstrating your engagement, your interest, to relay your understanding of what your patient is conveying to you back to them, through the process that's typically labeled as active listening. Try to allow enough time to address any misunderstandings your patient may have and address the questions they have. That's something that can be all too easy for us to overlook in the really challenging, busy lives each of us has as we're trying to quickly come to closure with any given patient. Unfortunately, when patients are dealing with pain, that is a singularly bad decision. We need to find strategies to have adequate time to engage, to listen, and to develop a relationship of trust. Part of that is showing empathy, saying things as appropriate in the context. If someone is experiencing chronic pain that has not responded to treatments as of yet, to be able to say, I'd be just as frustrated as you are. I understand this isn't easy. But to also be able to convey such thoughts as, we're going to work on this together, to not allow them to feel isolated and alone or abandoned. To say things such as, we can make gradual changes. We will find what works for you. And to address some of the underlying fears. We don't need to make abrupt or drastic changes as we work together to address your pain and improve your quality of life. It's important then to discuss options and the consequences of each option. So for opioids, there clearly can be acute benefits as well as substantial risks, and those will be covered subsequently. It's also important to recognize the vast range of non-opioid alternatives that frequently will work as well or better with fewer side effects than many of the opioid medications we have traditionally, over the last 15 or 20 years at least, turned to. Those can include anticonvulsants, such as gabapentin or pregabalin, lamotrigine, and others. It can include, and has for many years, the use of antidepressants, such as the serotonin and noradrenergic reuptake inhibitor class of medications, such as duloxetine or venlafaxine. And it can still include the traditional tricyclic antidepressants, such as amitriptyline or imipramine, which studies have suggested are as effective as any of the newer selective agents or, frankly, the anticonvulsants. It's also important for us not to overlook, where it's appropriate, the potential value of topical application of different medications that may ease some of the pain, whether through counter-irritant use, such as a menthol, or other nonsteroidals. And then there are non-medication alternatives as well. For example, physical therapy, acupuncture, meditation, and certainly cognitive behavioral therapies that can address many of the issues of the behavior associated with pain and of the suffering components associated with pain. So another way of framing this is that there are many approaches to treatment. And so if we're talking about neuropathic pain, obviously, if we can, we want to go to address the underlying disease-specific interventions wherever we can. Anything that can modify the underlying disease is far more effective than anything else we can do. If we cannot, or if that is ineffective or incomplete, then we go towards symptom management. And it can either be local or regional treatment or systemic treatment. The systemic treatment would be through medication or psychotherapies, as I've mentioned briefly so far. And then the local or regional treatments. I've mentioned topical or regional agents. There's also a range of stimulation therapies and certainly ablations, as well as physical therapy and rehabilitation. So there are many approaches to the treatment of pain, many tools that can be used, and it's important to recognize and to continue to make use of the full range of the differential therapeutic opportunities we have in trying to address pain. I previously mentioned the issue of risk and risk screening. because many people are at greater risk of becoming addicted to opioids than others. It's important to note, however, that any of us, all of us, can become addicted to opioids given the right situation, right doses, and the right context. But when we look at the risk screening approaches, there are many ways in which we are able to address them. And it's important to take the range of issues into context as we're addressing some of these factors. So, for example, social factors, family and friends. What is the support network that people may have? What's the environment they live in and work in? What kind of challenges or supports might they have? Further, is there justice involvement already? That would be a key issue in these conversations to assure that anyone with significant risks, we would be very cognizant before ever making an opioid prescription. There are medical factors to consider as well. Are there co-occurring conditions? For example, someone who already has an ongoing major depression is well over twice as likely to become addicted to opioids if they're exposed to them than someone without depression. So these are the different characteristics that are important for us to keep in mind. The financial characteristics are also important. What's their insurance status and their ability to pay for the kind of care that may be needed. As I mentioned earlier, using structured assessment tools for the assessment of pain can provide a substantial benefit to both you and your patient as it relates to the objectivity and consistency. So too, when we are screening for risk of becoming addicted, structured risk assessment tools are of enormous value. One such tool, but by no means the only, is something that has been labeled the Dyer score, D-I-R-E. And these stand for the different elements that are assessed. First, the diagnosis. And for each of these, the notion is that there are different levels of complexity and risk based on the diagnosis and the comorbidities. While we don't have time to go into the details here, I would certainly refer you either to this instrument, which is freely available online, or other structured risk assessment tools that you may choose. Similarly, the intractability or lack of reactivity of the pain to treatment is a second factor. Risk. And there are multiple domains within this element of the Dyer score. Psychological factors, their chemical health, whether or not they are already dealing with substance use disorders, or their reliance on multiple other chemicals. Their reliability as an individual, their ability to cope with the opioids. And again, there's social supports. So when you go through this series, that's D, I, R, and E, their efficacy. Are they able to function? Is there likely to be moderate benefit with improved function? Could there be good improvements in pain, function, and quality of life with stable doses over time? So based on the sum of these objective assessments, that will lead to a total score. A lower score would suggest that someone may not be suitable as a candidate for long-term opioid analgesia. A higher score is suggestive of someone who may be more appropriate for long-term opioid analgesia. So through this process, I wanted to convey the sense that it's important for us to think through before writing the first prescription and to routinely revisit prescribing of opioids to see whether or not the risks are worth the potential benefit. Then there's risk mitigation. Risk mitigation subsumes the notion that simply because someone may be at high risk, that does not mean that they cannot mitigate that risk. The way that we tend to do that includes a whole host of different opportunities. Certainly, the ultimate risk mitigation as a prescriber is going to be by not prescribing opioids in the first place. If we have, however, determined that the benefits of opioid prescribing outweigh the risks, then we may enter with our patient into a pain contract that would lay out in detail what are the obligations of the patient as well as our obligations as a clinician in caring for them and whether or not we will continue to be able to prescribe opioids safely to them. Additionally, safe storage in a locked box at home is an additional way to mitigate risk, not only for the patient, but for the patient's families and for visitors to the home. Providing naloxone as a rescue medication can be important and critical to also consider prescribing, certainly if there are prescriptions for benzodiazepines that are, or other medications that increase the risk of overdose. Additionally, having access to and reminding people of drug take-back boxes once they have finished using and they're no longer in need of any more opioid pills, to dispose of them through drug take-back boxes that are more and more available in pharmacies or other clinical settings, as well as being able to provide people with drug destruction bags or by giving them guidance about how to safely destroy any remaining pills rather than leaving them with the possibility that they might need them in the future. It's also important to think about tapering people off of medication and completely discontinuing medication, even if there may still be pain. Why and when might you stop prescribing opioids? Well, certainly if the treatment is ineffective or there are diminishing benefits, or as we are finding, there are mounting side effects. And it's important to coordinate the taper carefully to minimize discomfort and to reduce the risk of patients turning to illegal alternative sources. In this context, it's important to both document the fact of what you're doing in the treatment plan, as well as trying to make sure that you develop the treatment plan in collaboration with your patient to find alternatives that may indeed yield effective treatment for them. This brings us to the end of the third topic in Module 1, the challenge of discussing pain with patients. Thank you.